It's nice to reintroduce once again Professor Lars Lund from Sweden, Stockholm. He's professor of cardiology at Karolinska Institute. He's going to talk to us about the heart failure therapy real-world implementation. Please.
Yes, so it's a pleasure to speak again. Can you see my screen, the blue screen? So I'll speak now about real-world implementation, and I think it segues perfectly to Mark's talk about the SGLT2 inhibitors, the convincing evidence, and now the importance of implementing these drugs, and the issue of an algorithm adding one drug after another, or more of a horizontal approach, adding potentially several drugs at once. So if we summarize again, looking at the left in HFrEF, the key for success here is now implementing the existing evidence. And we have the 2016 guidelines, and in Europe, we have a 2019 consensus and 2021 guidelines coming up. And as Mark alluded to, the 2016 guidelines has an algorithm, and it'll be interesting to see what's going to happen dealing with all the new drugs that we have since then in the 2021 guidelines. In mildly reduced ejection fraction, we can consider expanding HFrEF therapy into mildly reduced ejection fraction. And in HFpEF, we have novel targets where we need to identify patients with TTR amyloidosis, patients with hypertrophic cardiomyopathy that might be candidates for novel therapy, albeit very expensive. Similarly, in acutely compensated heart failure, we have now one trial, Soloist, and others to come that suggests, or at least Soloist did suggest, that SGLT2 inhibitors are important also in acute heart failure. And then very recently, omecamtiv, a myosin activator that was positive, although not very impressive, presented very recently at the AHA. So looking back at the history, this is helpful because it tells us about implementation. So for 50 years, up until 1980, we thought of heart failure as pump failure. And the only treatment was replacing the heart. And it's interesting that our most advanced interventions, that is heart transplantation and mechanical support or left ventricular assist devices, were actually the first interventions for heart failure. The first heart-lung machine in the 1950s, ECMO, and then the first LVAD in the 1960s, together with the first heart transplantation in 1967. Then we began treating patients with drugs. The load hypothesis allowed that vasodilators would reduce the load and improve outcomes. But the key finding was this neurohormonal hypothesis that explained why heart failure kept getting worse spontaneously. Even though the myocardial infarction had occurred long ago, the patient with heart failure kept getting worse despite no new myocardial infarction. And that's why we understood the concept of neurohormonal blockade. And this has been the key success of the last generation. But then in 2014, and Mark touched on this too, came the first modification. This was Paradigm, in which we used a drug that had neurohormonal blockade, that is valsartan, but also one that harnessed the neurohormonal compensation, the natriuretic peptides. So it's no longer true for the first time, speaking of mechanisms, that all injury and remodeling leads to compensation, and this is all harmful. It is not as simple anymore that this is a vicious circle. Indeed, this endogenous natriuretic peptide system is protected. So this was a big leap forward. Not only did we now have a new drug, we also had a new concept in our understanding of the pathophysiology of heart failure and the treatment of heart failure. And then, of course, the SGLT2 inhibitors. This is on the same slide, showing again DAPA-HF to the left and Emperor reduced to the right, and then mentioning the meta-analysis that Mark spoke about also. So it's really impressive that now in patients with and without diabetes, with and without heart failure, with and without atherosclerotic cardiovascular disease. With and without CKD, we improve with SGLT2 inhibitors essentially all relevant outcomes for cardiovascular disease, including quality of life and decline of kidney function. It's an incredible advance. So now we look at the heart failure history, and at the bottom, we have much more complex mechanisms. The sacubitril valsartan was a neurohormonal modulation, and now the SGC stimulators, they work in many ways. They work on load, energetics, remodeling. We have SGC stimulators, very SIGWA, and we have omecamtiv, which had also beneficial effect outcome, but were not significant on cardiovascular or all-cause mortality. So we now have lots of drugs in heart failure and implementation. If we look here at a very interesting analysis from just recently, if you compare in a 55-year-old patient with HFrEF, the use of the 4 foundational drugs, ARNI, beta blocker, MRA, and SGLT2, versus the old way, ACE, ARB plus beta blocker. The MRA is also old, but it's unfortunately not well used. It's not implemented. So most patients today have only read ACE, ARB. If we did treat them with the 4 foundational drugs, we would add 6 to 8 years of survival or event-free survival. This is dramatic. These are drugs that make huge qualitative differences in longevity, not to mention risk of heart failure, hospitalization, and quality of life. So it's imperative that we implement these treatments. And then it gets even more difficult, and I really enjoyed some of the discussions and the program covering also on the top right, atrial fibrillation ablation, on the bottom right, mitral clip, on the top middle, cabbage in ischemia, or cabbage in HFrEF, and then also don't forget top left, heart transplantation, bottom left, LVADs, and also middle bottom, the CardioMEMS device and hemodynamic monitoring, allowing us to adjust our therapy. These are also now evidence-based interventions in HFrEF. So how are we going to master this? And this is, I don't have a technical poll here, but I just want you to think about, in your experience, what is the greatest barrier to patients receiving this incredibly effective HFrEF therapy? Is it side effects or concerns over side effects? Yes, to some little extent, we do have the risk of hyperkalemia. We do have the risk of early symptomatic hypotension, although these drugs, after weeks to months, the hypotension usually resolves and the symptoms resolve. Some criticize the trials for not being very generalizable, but with the most recent trials for SGLT2 inhibitors, for example, almost all patients with HFrEF would be eligible for those trials. Cost is, of course, an issue that's very variable depending on geographic region, but the SGLT2 inhibitors, as somebody pointed out, are actually quite inexpensive in most areas that I'm aware about. So I would say that the biggest problem is D. There's a lack of access to clinicians with adequate expertise. Patients with heart failure now really need to see someone who understands the 4 foundational heart failure drugs, plus additional drugs, plus how to handle diuretics, plus devices, catheter-based interventions, and surgical interventions. It's an incredible amount of evidence-based therapy that is very difficult for the generalist to manage. For example, in Sweden, which is relatively standardized, there's still a tremendous variation in the use of sacubitril valsartan, more than 3-fold looking at different regions in the country. And up until 2019, which this study is, only 69 per thousand, or 7% of patients with HFrEF and hypothetically eligible were treated with Entresto. And it's an exceedingly low number if you consider that paradigm was already several years old at this time. So implementation is poor. And if we look in a more rigorous fashion on the factors associated with implementation, we call this implementation science. We use detailed registries, cohorts, and government databases to look at what are the factors that determine non-use of effective therapy. So, for example, on the left, the most important factor for non-using Entresto in Sweden is age. The second most important is whether, as a patient, you're enrolled in the Swedish heart failure registry. So if you are enrolled in the Swedish heart failure registry, which is a quality registry, you're twice as likely to receive Entresto as if you are not. And indeed, in this study, we showed that in green, the top two lines, green and blue, are outpatients. The bottom two lines, green and blue, are inpatients. And during a 5-year follow-up, the mortality in blue is much higher. The mortality among patients who are not in the Swedish heart failure registry is much, much higher than among patients who are in green. So remember, the Swedish heart failure registry is a voluntary registry that has a coverage of about 50% of heart failure patients. So these two groups are about similar. So a key factor in doing well is being enrolled in a quality registry. Now you will say that, well, this is not randomized and these patients are different. Yes, indeed, they are different. The difference is that in green, in the registry, patients receive heart failure treatment. In blue, outside of the registry, much less so. So the registry saves lives by increasing the use, increasing implementation of evidence-based HFrEF therapy. So implementation science deals with what are the factors that improve use of available existing evidence-based therapy. Now, of course, this gets more complicated when we get down to very expensive and scarce interventions. So the first baseline treatment, so 4 foundational therapies, or at least ACE beta blocker and MRA are inexpensive, SGLT2 reasonably expensive, and ARNI more variable. But the 4 foundational therapies are all cost effective. All patients with HFrEF, in principle, have an indication and should receive these drugs. But when we talk about LVAD, or heart transplantation, or MitraClip, which is expensive, it's not enough to say that treating is better than not treated. We also need to say that it's substantially better. So looking at the left, for example, in a patient who's very sick and who would die without an LVAD, if the patient dies with an LVAD, that doesn't really help us. In the middle, if the patient would do really well with an LVAD, but would actually do quite well without one, we also don't get a big benefit and cost effectiveness. We really need to know the patients who have the biggest benefit in the bottom right, where without an intervention, outcomes will be very poor, and with an intervention, outcomes will be very good. And this is the key, and this is my last slide. This is the key to the notion of referral. It's incredibly important that patients with HFrEF get the opportunity to see a specialist, because they will not have all the 4 foundational drugs, and they should have. They may not have CRT or ICD, even though they should. And they may or may not be good candidates for additional interventions, such as AF ablation, pulmonary vein isolation, mitral clip, etc. And it is way too difficult for the generalists to know all the nuances of the criteria. What is the PVR that contraindicates heart transplantation? What is the peak VO2 that indicates heart transplantation? Which are the optimal patients for mitral clip? These questions are exceedingly difficult. So all patients with heart failure, all patients with HFrEF, should have the opportunity to see you, to see the clinicians that are interested in and aware of and able to treat patients with HFrEF. Thank you.
Thank you very much, Professor Lars. Just we have a dilemma here. We believe that you have two pathologies of HFpEF and HFrEF and mild reduced, okay? And now may you have a patient with a two pathology in the same patient, or continuation of the heart failure preserves the ejection fraction going to heart failure reduced the ejection fraction, as we see in ischemic heart disease, or for example. What do you think about that? Because if we have a patient have two pathologies and we have emerging two therapies and two strategies to control of both pathology, what do you think?
Right. It's a great question. I think that the guidelines and the evidence is limited. The guidelines are clear. Ejection fraction dictates therapy. Certainly, since ejection fraction is not black and white, there are many patients with features both of HFpEF and HFrEF. There are many patients with burned out hypertrophic cardiomyopathy or amyloidosis that progresses to HFrEF, or patients who has a small myocardial infarction. It really doesn't affect ejection fraction, mildly elevated NT-proBNP and filling pressures, and may never deteriorate. So if a patient has HFrEF, start all the medication. If a patient has HFrEF but then improves, please continue the medications. If a patient has HFpEF, we still don't have evidence in principle, mildly reduced, we talked about that in detail before, you may consider it. If the patient deteriorates and develops HFrEF, clearly, of course, start the medications. A question arises, for example, if a patient has a reduced ejection fraction and then improves and still has not received all the interventions, what do we do then? We really don't have any evidence. The patients who switch between ejection fractions, particularly those that improve, there is not much evidence for them. But certainly, if a patient had HFrEF, received all the drugs, and ejection fraction improved to 55%, we wouldn't implant CRT, even if there was dysynchrony. But would we start ARNI if the patient hadn't yet received it? In my opinion, we would not, because the patient is not anymore a patient eligible for the trials or according to the guidelines. But it's a really good point that you raise. Let the ejection fraction dictate. It's the best we have, as imperfect as it may be.
Thank you, Professor Lars. About the novel myotonic drug omecamtiv. Previously, it was indicated for acute decompensated heart failure. Nowadays, the American Heart Association 2020 last week presented omecamtiv as a novel drug therapy for chronic heart failure. What's your comment about this point?
Great question. So I'm very interested in the concept of contractility because despite all our advances, there remains a group of patients with HFrEF whose fundamental problem is reduced systolic function, reduced contractility, and reduced cardiac output, or very much neurohormonal compensation to maintain cardiac output. So when the novel inotropes or myotropes, for example, omecamtiv, but danicamtiv is another one, were developed, I was very excited for patients with advanced and acute heart failure. But I think given the fact that Amgen and Cytogenetics were able to develop omecamtiv as an oral drug, and given the fact that there was no available oral drug to improve contractility, they saw an unmet need in that population. And the trial was positive on the primary endpoint with a hazard ratio 0.92, I believe, if I recall correctly. So there was a modest improvement in the primary endpoint. But there was no improvement in mortality. It's a relatively complicated drug. So I don't think, based on the available data, that omecamtiv will be extensively used. However, I still believe that there is an unmet need in the smaller niche of very reduced ejection fraction, severe or advanced heart failure, acute heart failure, And if you looked in the subgroups of galactic, it was the patients with the more advanced heart failure that had a suggestion of benefit. So I'm involved in several projects targeting this advanced heart failure with novel myotrope approaches, but we are not there yet. I do not think, given the present information, that omecamtiv will receive widespread implementation.
Do you think that there is a criteria of a patient may benefit from this drug? Which patient may benefit? Which patient with
Right.
chronic
If I had to guess, it would be the patient with an ejection fraction less than 25 or 28, as in the trial, with New York Heart 3 to 4, with a high anti-pro-BNP. That is my guess, but this is just subgroups. It shouldn't dictate decisions in therapy. We need more focused trials with the myotropes, the novel inotropes, on specific heart failure. But if I had to guess, it would be the very low ejection fraction, the poor functional class New York Heart, and the high anti-pro-BNP.
Lars, thank you very much, but I will end by general questions regarding your last slide. Last slide about decreasing referral for expensive drugs. Do you think that 2021 heart failure guidelines will be changed, because in the last 2 years we have a lot of trials regarding drugs? For example, inotropes, Vagere, Victoria, and the galactic heart failure. So these are inotropes, and also now we have SGLT2, 2 or 3, and now SGLT1 and 2. So I think we can this scheme of treatment, which is yellow-green slide, this can be changed completely, and you can rearrange your pillars to be in the beginning in order to decrease the number referring for expensive and difficult task for left ventricular assist device, for transplant, or even for as a bridging for this. Because in our country, for example, it's very difficult to make this left ventricular assist device only one center, and also it's difficult. Remote monitoring is difficult. So I think you have to make it, even with developing countries like for those in the Middle East, to arrange for a new guidelines which is suitable for all heart failure patients with all pillars you have, because already now we have data, and this should be translated into practice, not onto theoretical basis and go direct to the devices. CRTs only may be reimbursed in some cases, otherwise I think treatment and treatment and treatment. What do you think?
It's a great question. So I don't think Andrew spoke, but he would have spoken about the different niches for different HFrEF interventions. And I can't speak about the guidelines specifically. It'll be very exciting to see them when they come next year. But in general, there's now so much therapy that I think that there's going to be a division into, first of all, foundational drugs, the 4 foundational drugs. Then there's going to be another category, which is add-on drugs, which do not improve mortality, but do improve heart failure hospitalization. That is digoxin, ivabradine, omecamtiv, and vericiguat. Then I think that there's going to be a highlight on the first-line devices, CRT and ICD, and a discussion of the aspects of AF ablation, MitraClip, cardiomems, stitches, CABG, etc. So there's going to be different categories. It will not fit in a simple algorithm anymore.
Okay, thank you very, very much, Lars, for your talk today, and 2 lectures, very distinguished lectures regarding the heart failure wisdom.